2 minutes to give you nutrition. Okay? And stop after 2 minutes.
You can get music like you were just leaving. Even you.
Le café n'est pas propre.
Non.
Ah, c'est lui qui m'a réveillé. C'est lui qui m'a réveillé.
But frequency of screening for patient under nutrition in CKD different in hemodialysis patient. In CKD patient, if patient weekly 2 or 3 more times monthly for outpatient with GFR less than 20 but not on dialysis. Within 1 month, if this patient starting dialysis, then 6 to 8 weeks later, screening may need to occur more frequently if the risk of undernutrition increase, for example, by intercurrent illness. But in hemodialysis patients, this patient is stable, well nourished, or malnourished or non-stable. A stable and well-nourished hemodialysis patient should be interviewed by a qualified dietitian every 6 to 12 months. 3 months if this patient over 50 years or started dialysis 5 years. Malnourished hemodialysis patients should undergo at least 24-hour dietary recall more frequently until improved. Malnutrition in CKD, chronic kidney diseases, and hemodialysis patients, clinical studies have shown that renal patients may have inadequate dietary intakes during the early stages. 40 to 70% patients in the stage renal diseases are malnourished. Protein energy malnutrition should be avoided in maintenance hemodialysis because of poor patient outcome. 2 types of malnutrition, type 1 and type 2, has been described in CKD patients. The causes of protein energy wasting or protein energy malnutrition because decreased dietary intake or nutrients intake results from loss of kidney function, uremic toxins, comorbid condition, dialysis-associated catabolism, metabolic derangements as hypertension, metabolic acidosis, and inflammation. And the consequence of protein energy wasting, infection, cardiovascular diseases, and depression. My target on patient different between age stages. In pediatric patient, by using system called Beatles-Beck system. CKD can focus on pediatric patient for growth, adult, promote health, geriatric, maintain health, end of life, minimize aging effects to improve quality of life. All stages to improve quality of life. Why that is important? In CKD, different in hemodialysis. In CKD, maintain optimal nutrition status, prevent protein energy malnutrition, slow the rate of disease progression, prevention of complication and other medical conditions as diabetes, hypertension, dyslipidemia and cardiovascular diseases, anemia, metabolic acidosis, and secondary hyperparathyroidism. In hemodialysis patients, renal diet minimize the amount of wastes, a good meal plan choice, minimize build-up of waste products between session of treatment, improve nutritional and functional status, and conserve muscle mass. Nutrition care process steps: ADME, meal, assessment, diagnosis, intervention, and monitoring and evaluation. The steps of nutrition care process. How can we assessment of nutrition status? History and physical examination, looking for loss of weight and muscle wasting. Dietary history. Dietary history of this patient using methods, many methods, as 24-hour recall this patient. With a patient in hemodialysis, we can using 24-hour recall 3 days. Dialysis day, what we eat. Between dialysis day and the holiday. And using food frequency questionnaire type of foods. He consumption daily or weekly or monthly of this patient. Subjective global assessment rated to 4. You should including this patient of all sheet. Anthropometry, biochemical or laboratory tests is albumin can predictor mortality and in this patient, a renal patient. strong predictor of morbidity and mortality. However, albumin affected by non-nutritional factors as infection, inflammation, comorbid conditions, fluid overload, inadequate dialysis, blood losses, and metabolic acidosis. Albumin may not increase in response to nutritional intervention. Relative risk increasing when albumin less than 4, but risk decreased when BMI over than 4 milligram per deciliter. There is no single magic nutritional index. How can we monitor and follow up nutritional status about body mass index? This equation of body mass index equal to weight kilogram divided by height meter square. We can classify it our category or normal, malnourished, underweight patient, or overweight, obese, with all classes, class 1, class 2, or class 3, about this table. Normal patient, when result of this equation between 18.5 to 18.5 to 24.9, but obese patient starting from 30 or over them. In hemodialysis, patients should maintain a BMI over than 23. This equation using when we calculate the body weight of this patient, ideal body weight. This equation for men and women, female or male. Okay, but if actual body weight, if this patient comes to you, actual body weight over than ideal body weight over than 30%, what we can use? Ideal body weight or adjusted body weight? These questions. If actual body weight, if a patient comes to you, an actual body weight of this patient over than 30% of ideal body weight, what weight we can calculate?
If you have a patient, the ideal body weight is 60 kilograms. But when you measure him in the scale, it's
100.
okay. What measures you will use is very important. Because also we have dry weight that will come later.
Okay. We can use other equations, adjusted body weight from this equation. This is important for calculation requirement intake of this patient. Interdiabetic weight gain between session of treatment, general recommendation plus 2 kg per session. But if this patient comes to you over than 5% fluid gain, this may excessive fluid intake or weight gain. But if this patient comes the session of hemodialysis, less than 20% fluid gain may be inadequate fluid and or fluid intake or food intake, or weight losses, body mass index is decreased. This form of subjective global assessment rating form, including 3 parts, main 3 parts. First part, history of this patient, including weight changes over 6 months or over past 2 weeks, and we calculate it, significant loss or not. Second part, food intake, unusual or usual intake, appetite of this patient, duration, weekly, and fluid intake. 3 parts. Third, اللي هو GIT symptoms, anorexia, vomiting, constipation, and other complications we can see with this patient. Second part, physical examination. Is this patient mild or moderate physical examination, or sedentary, working or not working? At the end, third part, overall subjective equilibrium assessment. Normal or poor NASH patient rating of 6.7 in most categories, or significant and improvement. Mild or moderate malnourished, if this patient rating of 3 to 5 rating. Severely malnourished, if this patient rating 1 to 2 rating. Second part of this talk, including diet plan. How we can diet planning for this patient. Is dialysis effective? Effect of nutrition? Any answer? Yes?
Because yesterday we were talking about peritoneal dialysis. I said yesterday there is amino acid loading in the bags of peritoneal dialysis. But also in hemodialysis. Hemodialysis per se itself affect the nutrition of the patient? Yes or no? Yes?
Yes.
Yes, strong yes, not only simple yes, strong yes.
From catabolic effect of dialysis, hemodialysis and peritoneal dialysis. Loss of amino acids in hemodialysis 6 to 8 to 10 gram per dialysis or treatment session hemodialysis, but in BD 2 to 4 gram per bag. If this patient using 4 bags per day peritoneal dialysis losses 16 gram per day. Losses of glucose. In hemodialysis patient, glucose, dialysate free glucose. So we should encourage patients take simple sugar during dialysis session of dialysis. Didn't advise him to eat during dialysis. To avoid it, hypotension during dialysis. But we can advise him take simple sugar during dialysis to avoid it hypoglycemia. Second.
Also one of the important issues to advise our patient not to take insulin before the sessions. Insulin. Because
For diabetic patients,
yes, diabetic patient. Because hemodialysis are removing the glucose from the body.
25 gram per dialysis.
Because as Dr. Doaa said, we are using free glucose dialysate. There is glucose with that all of our most of our countries using free glucose dialysate and they are losing blood sugar there. So please always advise the diabetic patient not to use insulin before the okay.
Okay. Dialytic adequacy. This study advised daily hemodialysis 6 sessions per week. Results improve appetite and food intake, general feeling of well-being, increased physical activity, fewer dietetics restriction, decreased dose of medication, phosphate, potassium binders, anti-hypertension drugs, increased clearance of potential anorexic factors, improved serum albumin levels. Dietary recommendation of this patient, our renal patient, kidney kitchen. Diet focus in CKD different between hemodialysis. Important nutrients in CKD: calories, protein, carbohydrate, fat, and cholesterol, and phosphorus restriction started from stage 3. In hemodialysis, calorie, protein, carbohydrate, fat, and sodium and fluid restriction to avoid it with interlate will gain session, between session, potassium, phosphorus, and calcium. And diet goals of hemodialysis: control of minerals, hyperphosphatemia, hyperkalemia, hypocalcemia of this patient. We will start about nutrients, calories. Calories, adequate energy intake, essential to optimize nutrition status. Present in calorie from carbohydrate, fat, protein. 1 gram carbohydrate equal to 4 kilocalorie. 1 gram protein equal to 4 kilocalorie. But 1 gram fat equal to 9 kilocalorie. How we calculate calorie intake of this patient? Depending on current weight loss goal, age and sex, and physical activity and the metabolic stress of this patient. Guidelines, or generally, we can calculate calorie intake of this patient depending on age of the patient. If this patient less than 60 years, we can calculate calorie intake 35 kilocalories per kg per day. But if this patient over than or equal 60 years, we can calculate nutritional needs of calorie 30 to 35 kilocalories per kg per day, according to physical activity of this patient. So, regular physical activity should be encouraged and energy intake should be increased according to level of physical activity. According to physical activity of this patient, we can calculation, you need 30 or 35 kilocalories per kg per day. Second point, protein. 1 gram protein equal to 4 calories per calorie. Essential protein essential for building muscles, repairing tissue, fighting infection, and keeping fluid balance in the blood. There are 2 kinds of protein. High biological value protein from animal source, but low biological value or plant source. Animal source as meat, fish, poultry, eggs, and dairy. Essential, including essential amino acids. This is called high biological value. Low biological value, plant protein and bread, grains, cereals, vegetables, dried beans, and meat and fruits. We should encourage patients to take high biological value between 50 to 70% of requirement intake of protein according to requirement. But all well-balanced diets for kidney patients should include both kidney kind of proteins every day, high biological value and low biological value. We can use protein alternative, protein bars, protein powders, supplement strengths. Protein intake. Different stages chronic kidney diseases or in dialysis or replacement renal therapy. In stage 1 to 3, 0.75 gram per kg per day. In stage 4 or 5, not on dialysis, 0.6 gram per kg per day. But in stage 5 on dialysis or renal replacement therapy, peritoneal dialysis or hemodialysis, 1.2 to 1.3 gram per kg per day. For example, if this patient weighted 68 kilogram, we can calculate protein intake all the day, 55 grams, half of cup of milk, 1 egg whole egg or 2 egg whites, and 3 ounce meats, 3 portions of vegetables, and 3 portions of fruits, 8 serving of grains. The source of protein food categories or food groups. If this patient in CKD stage 4 or 5 not on dialysis, we need to calculate protein intake all the time of day, 41 to 48 grams per day. But if this patient starts with dialysis, peritoneal dialysis or hemodialysis, the amount of protein duplicated, 82 grams of protein. For the stages of malnourished patients, eat additional protein.
I think all of us in our daily experience not giving our patient enough food. We are trying to restrict our food, the food of the patient, to decrease the serum creatinine level, especially in for dialysis. I think so, our experience, at least our experience in Egypt. But I think even in dialysis patient, we have to encourage the patient to eat, but the suitable food. Because still the patient coming to dialysis with restricted diet. So I think we have to encourage the patient to eat, but without we eat the suitable food. Okay?
Yes. Potential benefit of low protein diet in chronic kidney diseases: uremic toxins disappear, especially nausea, vomiting, reduce the burden of uremic toxins, urea, acidosis, potassium, phosphorus, and others. Slow progression of renal failure, reduce proteinuria, improve nutrition status, increase insulin sensitivity and glucose tolerance and antioxidant effect. No protein restriction for dialysis patients because hemodialysis treatment loss of 10 to 12 gram loss per session. Lipids. Patient with renal diseases or chronic kidney diseases considered high risk of cardiovascular diseases because all patients suffering from dyslipidemia. Nutrition therapy for dyslipidemia is based on patient metabolic profile and individualized treatment groups. Requirement of fat: 30% of total care. Minimize the requirement in terms of fat if this patient lab tests increasing triglyceride or cholesterol. Generally, we can divide this percent to saturated fatty acids and unsaturated fatty acids, with saturated fatty acids to mono or polyunsaturated fatty acids, and decrease intake of cholesterol per day to 250 to 300 milligram per day. Omega-3 fatty acids decrease triglyceride and cholesterol, as well as phospholipids may be tried. Lipid disorders. This study shows that in patient with CKD and hemodialysis patient with peritoneal dialysis or replacement renal therapy, transplantation, hypertriglyceridemia, and often normal cholesterol but low HDL cholesterol. And we increased HDL, the source of from foods, and omega-3, fish oils, carbohydrate. Requirement of carbohydrate calculation: thickest 65 70% of total care. This percent divided to 70% complex sugar to reduce triglycerides and improve glucose tolerance. Second part, 30% simple sugar. But pay attention. In peritoneal dialysis, dialysate fluids contain simple sugar. Divided this amount from intake from foods. We decrease simple sugar content in foods because peritoneal dialysis bags contain simple sugar to avoid triglycerides. Carbohydrate intake may need to be modified for patients with diabetes to achieve the goal of hemoglobin A1C less than 20%. Do you know carbohydrate counting? Any person listen? Carbohydrate counting? No?
Knows all of us are giving the patient, especially insulin, fixed dose of insulin. We are giving the fixed dose of insulin, so we have to fix it of the diet of the patient.
Yes. And the type of insulin. If type insulin, long acting or short acting, time of meal, this called carbohydrate counting. According to dose of insulin, we calculate carbohydrate needs of this dose and the type of insulin, long or short acting. Fiber intake, optimum fiber intake 20 to 25 gram per day. This study about high consumption of dietary fiber intake is associated with decreased inflammation and all causes mortality in patients with chronic kidney diseases. Fiber intake encouraged patient fiber intake because dietary fiber from vegetables and fruits it rich antioxidant to decrease inflammation and oxidative stress. Dietary fiber increase activity of colon microbial to product short chain fatty acids to decrease insulin sensitivity and lipid absorption of lipids. All of these factors decrease inflammation and oxidative stress and cardiovascular diseases with infectious diseases. Sodium plays vital roles in regulation of fluid balance and blood pressure. In CKD and hemodialysis patients may result in high blood pressure, fluid retention, edema, lead to shortness of breath, excessive thirst, and congestive heart failure. Source of dietary sodium. Main source of dietary sodium from processed and restaurant foods, fast foods, processed foods. Source of sodium or hidden sodium about benzoate sodium, citrate sodium. So we should attention nutrition practice labels all food processed. Tips to decrease sodium intake. First, cook at home with low sodium ingredients. Cut out salt, high sodium condiments, processed or cured foods. We can add herbs, spices, lemon finger. Eat out less, especially fast foods. Read labels of all products. To decrease sodium intake, 1 to 4 milligram per day. Fluids. Fluid didn't water only, but any foods that it's liquid at room temperature, as soup, gelatin, ice cream. In hemodialysis, requirement or calculation requirement intake of fluids according to urine output of this patient. Urine output plus 1 liter of per day. To maintain interdiet weight gain of this patient between 2 to 5% estimated right body weight. Excessive fluid build up, edema, hypertension, congestive heart failure, and breathlessness, delay on healing. Fluid restriction estimation are based upon urinary output, disease state, treatment modality, dialysis, or others. Tips for thirst and fluid control. Take your fluids, avoid chewing of ice, avoid reflux at restaurants because content of sodium, high in sodium intake, and the high in sodium intake increase thirst. Small glasses and at meal or medication, added lemon or lime juice to water. In hot weather temperature, keep your skin cold. This is advice of this patient. Keep your lives moisture with cheap stick. Keep your mouth wet. Keep your mouth clean. Rinse your mouth with cold water, but don't swallow it. Rinse your mouth with shared mouthwash. Chewing on gum, dry lemon wedges or processed grapes or fresh fruits. If this patient diabetic, we should control blood sugar.
You have experience in your patient with high intake weight gain. You have. Because I'm expecting in Africa the weather there make this still you have there.
Sodium and fluid. The requirement for sodium and water varies markedly, and each patient must be managed individualized about according to interdiet weight gain, blood pressure, and residual renal function of this patient. Increased restriction of sodium fluid if this patient increased interdiet weight gain between sessions, congestive heart failure, edema, and hypertension. From this table, we can calculate fluid output, fluid intake and sodium intake according to fluid output, our urine output of this patient. If this patient fluid output over than 1 liter per day, we can calculation sodium intake requirement intake between 2 to 3 grams per day, and fluid intake 2 liters per day. But if this patient less than urine output less than 1 liter per day, sodium intake decreased 2 grams and fluids 1 to 1.5 liter per day. But this patient, if anuria, sodium intake 2 grams and fluid decrease 1 liter per day. Phosphorus, high phosphorus, serum phosphorus lead to bone decalcification, soft tissue calcification, hyperparathyroidism. Dietary intake approximately 800 to 1,000 milligram per day, or less than 17 milligram per day. According to labs of this patient, if he suffering hyperphosphatemia, we can calculation requirement to intake to phosphorus 10 milligram per kg per day. Hemodialysis removes 500 to 1,000 milligram per treatment. Binders removes 50% of dietary phosphorus. We can control the phosphorus intake, serum phosphorus per day by three best ways. First way, binders. Second, diet, and adequate dialysis. How we control phosphorus? About diet. We found as chemical structure of phosphorus two types: organic phosphorus and inorganic phosphorus. Organic phosphorus found on most foods naturally and absorbed between 40 to 60% Naturally, food dairy products, meat, poultry, fish, soya, dried beans, and whole grains. Some of this food contain phytate, as whole grains and dried beans. Phytate decrease absorption. We can absorb it between 20 to 30% only. But in organic phosphorus, it found in food additives, dairy supplements, calcium fortification, absorbed over than 90%. But phosphorus binders ineffective of this type of inorganic phosphorus. But when we take phosphorus binders, which means natural foods, these phosphorus binders effective and decrease absorption.
So you went to meaning the most dangerous time is the organic time.
Yes.
Because the phosphate binder is not effective.
Yes.
So we have to be careful about this organic time. Okay?
Yes. In organic foods found in most products artificial. So we can read the ingredients list. We should. In diet, found foods high phosphorus and other type low phosphorus intake. Low phosphorus intake or low phosphorus content of these foods found in fresh fruits. High content, first high content of phosphorus found in dairy products, nuts, seeds, bean nuts, dried beans and peas, bran, cereals, whole grains products, beverage as artificial source and absorption of phosphorus from beverage over than 19 to 19%. As cola, dark cola drinks or beers, all types of beverage. But low phosphorus foods including fresh fruits, fresh vegetables, popcorn, crackers, rice, cereals, sherbet, coffee or tea without milk. But we should attention content of fresh fruits and fresh vegetables content of potassium. We should food selection of this type of foods, fruit and vegetables, low content of potassium. Control phosphorus about binders. Binders are like they soak up phosphorus from foods in the GIT tract, must taken with meals. We advise patients you should take phosphate binders with meals, especially main meals. And we found several types of phosphate binders we can use by physician. Control phosphorus dialysis. Phosphorus clearance is effective only during the first 2 hours of dialysis. Serum phosphorus levels don't change during the second half of dialysis. We can encourage the patient go to peer session of hemodialysis. Don't miss any day. How we can balance of phosphorus from diet and adequate dialysis. If this patient calculation take phosphorus per week 4,200 from diet, we can remove by binders minus 2,100, and by hemodialysis removes 2,100, then we balance phosphorus.
This is the point of adequate dialysis. In a book about diet, without adequate dialysis is book. Adequate dialysis is the key point for diet. If you see here, patients are missing dialysis. Patient trying to short their dialysis. Have to push the patient to have 4 hours 3 times a week, and you have to calculate the KT over V and URR to have the adequate dialysis. Adequate dialysis.
These three ways, the best 3 ways to control phosphorus. Calcium. Requirement intake of calcium in the stage 1 to 4, 1.2 to 1.5 gram per day based on that requirement intake. It may need a vitamin D3, active vitamin D. In CKD stage 5 and hemodialysis patient, not excess 2 gram per day, including calcium phosphate and all phosphate binders. We can use active vitamin, and important to control parathyroid hormone. Renal diet is approximately 500 to 800 milligram per day. That is low because many foods of high in phosphorus and calcium, high in phosphorus in the same time. Potassium in CKD stage 1 to 3, usually not restricted. In CKD stage 4 and 5 and hemodialysis corrected according to the level of this patient. But in hemodialysis, in peritoneal dialysis patient, 35% of this patient suffering from hypokalemia. But in hemodialysis, different, most of patients suffering from hyperkalemia. That equals is usually 2 to 3 grams per day, adjusted per serum levels, dialysis bus concentration. Potassium found in fruits, mostly in fruits and vegetables. We can classify it source of potassium, foods about source of potassium, low potassium, medium potassium, high in potassium. Low potassium is apples, pineapple, cabbage, eggplants. A high potassium, oranges, banana, potatoes, mango, melon, avocado, tomatoes, nuts. portion size is essential. We can use high concentration of potassium, but a small portion. Avoid salts, potassium chloride, and we should attention about dairy. 1 cup of dairy, including 380 to 400 milligram per 1 cup. And dairy high in content of phosphorus. Dairy content high in potassium and high in phosphorus. Micronutrients. Renal multivitamins contain water-soluble vitamins, dialysable, take after dialysis. Supplementation may improve iron availability from stores. We should attention vitamin C in renal vitamins, limit total vitamin C to 60 to 100 milligram because high vitamin the increasing vitamin C, increasing oxalate, and due to calcification of soft tissues and kidney stones. Individualized iron, vitamin D, calcium, zinc according to level of this patient. In the end of my session, nutrition in CKD, chronic kidney diseases and hemodialysis patient, assessment about dietary history and any changes in dietary intake, weight history, subjective global assessment rating form, as we show, underlying medical conditions, biochemistry, GIT symptoms, social and psychological factors. We started management oral diet. When oral diet is not enough, we can take or advise this patient oral diet plus extra snacks is not effective. We can use supplement. If oral diet and supplement not enough for this patient, we can use your feeding, enteral feeding. If this all methods not enough for this patient, we can use total parenteral nutrition. Most also optimize medical management, dialysis, adequacy, acidosis, and infection. Conclusion today. Poor nutrition is common in chronic kidney diseases and hemodialysis patients and has adverse risk factors. Nutrition counseling part of approach of chronic kidney diseases and dialysis patients. Routine nutritional screening and assessment should be done for chronic kidney diseases and dialysis patients. Qualified renal dietitian must be included in the staff of every dialysis unit. Personalized nutritional plan worked out for every patient as individualization.